Welcome, everyone. I'm Melissa from the team here at Let's All Talk Menopause. And we are delighted that you're joining us to learn more about how you can thrive during your peri/menopause journey. I'm especially pleased to welcome you to a special edition of tonight's program, which is part of a medical education series, Managing Women's Health and Menopause, which is courtesy of an educational grant supported by Astellas Pharma Global Development and Bayer Healthcare Pharmaceuticals. The clinician education components are being presented on menopauselearning.com. And Let's All Talk Menopause is delighted to be presenting the patient outreach component. I would like to thank Dr. Holly Thacker, the chair of Managing Women's Health and Menopause, and recognize the work she's doing with speakingofwomenshealth.com, a wonderful resource for patients that provides an abundance of information on women's health issues. So thanks to the grant this evening, I'm pleased to welcome Dr. Alexa Fiffick to speak on the topic of menopause, vasomotor symptoms, and breast cancer. And Dr. Fiffick is a board-certified family medicine physician and specialized women's health senior fellow at Cleveland Clinic. She received her master's of biomedical science from Geisinger Commonwealth School of Medicine and her doctor of osteopathic medicine from Alabama College of Osteopathic Medicine. Today, Dr. Fiffick will be helping us understand more about what vasomotor symptoms are, why they occur, and the treatment available, particularly if you are a breast cancer patient or survivor. And as always, we want you to be part of the conversation, so have your questions ready. Don't forget, place them in the chat, keep them as general and non-specific as possible, and we will get to as many of them as we can. And with that, I'm delighted to welcome Dr. Fiffick. It's great to have you back on the show again. Thanks for joining us.
Be here. Thank you for having me.
Oh, it's always a pleasure to have you. And you know, we've got a pretty hot topic, which is my pun for the evening. I promise to be done after that. But we're going to talk about vasomotor symptoms, right? How to achieve quality of life that people are looking for, but also that we deserve as women, right? And while we're experiencing these symptoms, what can we do? And then we're going to layer in the added challenge of managing these symptoms with breast cancer or with concerns about breast cancer. So, you know me, I always like to start at the beginning. Let's start by just defining what vasomotor symptoms are. What are the common symptoms and names and why they occur before we get too far into what we can do about it and how it affects you if you are concerned with cancer.
Yeah, absolutely. So vasomotor symptoms is the big medical term for what everyone else knows is hot flashes and night sweats. That is the most common way that most Americans and other people in Europe are capable of understanding those terminologies. However, there are certain cultures in which hot flashes are more interpreted in kind of a cold sense. So any sort of drastic fluctuation in your perception of temperature is what we're talking about with a vasomotor symptom. So,
well, I hadn't heard about cold flashes. So there are certain cultures where instead of the immense heat, is it immense chills?
Yeah, so there's the phenomenon that we understand that's happening when you're actually having a hot flash is that your body is unable to regulate against certain very small, minute kind of temperature changes in the environment around you. So say you walk from your office to the hallway and it feels, 5 degrees colder. That sort of trigger is really difficult for the brain that's going through the menopausal transition to kind of regulate out. So what happens is that flash, and then a lot of women experience cold chills, shaking chills after the fact. And the interpretation from the research so far is that sort of interpretation of the cold flash is what's being experienced. There may be some climate differences with that as well in countries that tend to be hot more often, where that cold is really what's more noticeable.
Interesting. No, that's really interesting. So today I think we're going to focus more on the hot flashes, the night sweats, what have you, and we'll go from there. So why do vasomotor symptoms occur? What's going on physiologically?
So for a long time, we used to think that the hot flashes were explained completely by the decline or deficiency of estrogen. That was especially thought when people were given hormone therapy and those hot flashes immediately started going away. But it turns out that from more of the research that's been done, there's neurons in the brain in the thermoregulatory zone called the hypothalamus. So this little tiny section of the brain cannot kind of respond to those changes in temperature because they're kind of destabilized by the changes in estrogen. But turns out also there's a bunch of other kind of different chemical messengers that can bind to cells in that thermoregulatory zone. So it explains further a little bit why maybe some women don't actually get complete resolution with estrogen, or that estrogen isn't the only part of the story. It's a little bit more complicated.
Gotcha. Okay. So the estrogen tends to have an impact on the hypothalamus, but it's also the estrogen itself. And we've chatted before, and we sort of, it was surprised to me when I first started learning all this, how estrogen really, sort of impacts every major organ in the body. But for some reason, vasomotor symptoms seem to be, in the US anyway, one of the top offenders of peri and menopause. And do we know why that is?
I think it has to do with the kind of cell binding that occurs in the hypothalamus. I think there has a lot more to do with sort of the role that estrogen plays in that sort of stabilization. But as far as it being what we think is like the most common symptom, I don't know if we have an answer for that yet. We know that the lack of estrogen or decline in estrogen also causes things like bone loss, vaginal dryness, etc. But really those vasomotor symptoms may be pointing to other involvement with the estrogen beyond just the experience of the flash.
I see. And if you're going to menopause, or perimenopause, I should say, because really perimenopause is when most of these symptoms are occurring. So maybe we just take a quick second and define perimenopause versus menopause, if you would, and then I'll ask my question.
Yeah. So menopause is defined as the time point from the last menstrual period that a woman has until 12 months after that. And that 12-month period has to be absolutely bleeding free. Once you pass that 12-month point, we can retrospectively call you menopausal. But between having normal, regular periods, no symptoms, and going about your life ovulating or using birth control without any symptoms, up to the point of being past 12 months with no period, that's perimenopause. And that's where the majority of women are suffering.
And that can last for a very long time, right? I mean, the average length of perimenopause
is like 7 to 10 years.
That's so long. It's so long. Why aren't more people talking about this? I'm glad we are. So back to my question then. So if you go into perimenopause, because that's really where you're experiencing most of these symptoms, let's say later in life, because we know that some people, if it's not surgically induced, so let's take that off the table, just naturally starting to go into perimenopause. Some people can start going to perimenopause in their 30s, others in their 40s. That's a big decade gap. Do people experience I guess, varying symptoms or varying degrees of vasomotor symptoms based upon earlier versus later?
So there has been some data that shows that people who are undergoing a little bit earlier naturally tend to potentially have a longer course of the symptoms. Potentially, there's also something to be said about the fact that we know that women who actually transition into menopause later in life likely have a longer lifespan and have better health down in the long term in their later years. So I think that it's definitely an area that still needs to be studied, because I think depending on whether it's surgical or natural, we need to have better answers. Yeah.
Gotcha. And let's bring, I know we talked a little bit about climate, but let's bring race into this as well. Do vasomotor symptoms vary in severity by race?
Yeah, so actually there's data from the North American Menopause Society that shows that Black women and women of Hispanic backgrounds also tend to suffer the most and the longest from vasomotor symptoms, followed then by white women and Asian women.
Wow.
Yeah, so I'm not honestly very sure if we have a good answer about whether or not that is something that is pathophysiologic, or if it plays into the racial disparities that we see in healthcare as well. I imagine there's probably both, just like there is for most other health conditions. But yeah, so it does differ by race. So I do always recommend that my patients really try to speak up for themselves, because there's no point for you suffering more than you need to.
Yeah, and it can be, I mean, aside from just, soaking through your clothes, keeping up at night, it can be embarrassing and it can be anxiety inducing. I mean, there's a lot of different ways to look at vasomotor symptoms aside from, oh, so you're a little warm, right? It really has a tremendous impact. A question that someone had sent in, which I think it fits right now, so I'm going to ask it, is, if I have extreme vasomotor symptoms, can that also be indicative of other challenges I should expect to have going through perimenopause and menopause, or are there no correlations?
So, not to scare anyone, but we do have some data that vasomotor symptom severity is associated potentially with cardiovascular disease. So, things
Okay.
like heart and brain health, you want to make sure that you're talking to your doctors about that, because there is some correlation that women who suffer more and worse from vasomotor symptoms are likely at a higher risk of having heart disease. Same to say with women who have anything else that kind of changes the stress on the cardiovascular system. Think like migraine headaches or some autoimmune conditions. All those things all kind of also play a role.
So that's interesting. I don't know that I would have thought of vasomotor symptoms stressing your cardiac system. Can you tell me a little bit more about that?
Yeah, so there's been data that shows that women who suffer with a higher frequency and severity of hot flashes actually are having changes to their brain occur that look like what we call microvascular dementia, or little tiny lesions in the brain where the vessels that we're feeding it, the little skinny vessels of that carry blood up there, are having a little bit of damage. And I don't think we know yet if it's like the chicken or the egg. Is it the vasomotor symptoms that are causing that? Or is it that that woman is more predisposed to cardiovascular disease, that she has worse vasomotor symptoms? The jury's still out on that research.
Gotcha. So maybe just to give everybody a little bit of ease, when we talk about severity of symptoms, I mean, because a hot flash here and there is here and there. It's if you're flashing every day, flashing multiple times a day, like, well, how would we define severity?
Yeah, so severity, I like to think of the amount of times per day and or night. So you'll hear a lot of patients say, oh, I only flash at night. I'm not having hot flashes, I'm having night sweats. But that kind of number starts racking up. And I think that once you're having multiples per day, you're in that moderate to severe category.
Okay. All right. So multiple per day. That's super helpful. So we've got a little bit of a background on vasomotor, and it's mostly hot flashes, which then lead to sleep challenges, right? Are there any other, when we talk about vasomotor symptoms as a class, is there anything else we should be including in that?
Yeah, so the vasomotor symptoms, typically you will get patients in that come and talk about feeling like they're having an anxiety attack. And it's more actually the vasomotor actual experience where they get flushed and hot and they feel like their heart's racing, or they feel really nervous. So sometimes panic attacks or anxiety attacks tend to kind of actually be the vasomotor symptoms showing up. And then a lot of times patients will say, I'm not experiencing a flash, but I just wake up 5 times a night. So my question is always, are you waking up and it's like, oh, I have to pee. Oh, I'm having a panic attack, something. And if they tell me, no, I don't really know why I'm waking up, I just can't sleep, I like to argue that your brain is experiencing the hot flash and then you wake up. So you may not be cognizant of it, but it's happening.
Okay. All right. So let's start to talk now a little bit about some of the relief that people can start to think about. And let's bring breast cancer into the mix as we talk about this. So maybe we start on the holistic side. So we start thinking about some of the holistic options before we dive into the hormone replacement therapy side. And as we're talking about this, let's think a little bit about how a diagnosis of breast cancer or concern about breast cancer, does that make us think any differently about some of the symptoms and how we might want to manage them? So if I am a breast cancer patient or a previvor or a survivor, and I'm starting to look at holistic options, like looking at different types of supplements, thinking about diet, etc. Let's talk about what some of those remedies are. And then let's note if there are any that are specifically better for someone with concerns with cancer, or things that ideally, because we don't know everybody's individual patient history and we're certainly not prescribing anything today, things that they may want to consider staying away from until they really get their doctor's, okay on it.
Yeah, absolutely. So I usually come out of the gate saying that I recommend all my patients, whether or not they are someone who's on hormone therapy, or if they can't be or choose not to be on hormone therapy, I make these recommendations across the board because they're supported by data.
Okay.
So some of the easy things to do are to help you adjust to your environment. So always dressing in layers. If you're like me, you pretty much always have a sweater or a jacket around and probably 2 pairs of socks. But keeping things that can come off easily and lighter layers can be really helpful. Keeping your environment cool. I know that premenopausal women tend to be colder in the work environment, and menopausal women tend to enjoy the fact that the environment is a little bit chillier. Specifically, about 68 degrees Fahrenheit in a bedroom at night has been shown to decrease hot flashes at nighttime.
Okay.
Things like exercising, it's good for you overall, but there has been some data to show that things like pretty much daily or multiple times per week exercise can decrease the frequency as well. And then if we're getting into things that you could be kind of avoiding, obviously these are good for cancer prevention as well, but alcohol, tobacco are both really bad stimulants for hot flashes and night sweats. I very frequently have patients say, I knew it was a trigger when I went to that wine trip with my girlfriends and I drank that cab, and next thing I know, that night I was flashing. So making sure that you're not only looking at it from the overall big picture, but paying attention to some of what your triggers are. Some people, it's spicy food, chocolate, sun exposure, etc.
But so just so I'm clear, so like I have a glass of wine, it's not an instantaneous reaction. It would be a few hours later. So I'd have to think about, did I do anything different that day?
Yeah. Typically, it'll be later in that evening. It's sort of, I like to think of it just sort of like lowering the threshold for your body to sort of respond to the things around it. And I think alcohol kind of works in that manner.
Okay. Gotcha. And then I know, we've had Dr. Neil Barnard on a few times, and I know he talks a lot about diet. Now you talked a little bit about alcohol, tobacco, things like that. They're stimulants, but also are there other food groups that are recommended to either eat or stay away from, aside from the ones that they tell us to stay away from for everything?
Right. Yeah. So there's some data to show that diets high in sugar are potentially a trigger as well. I don't like to make tons of like very strict recommendations because I don't like, I eat like a normal American too. I think it's difficult to make great choices all the time. But if you're eating cake after dinner, having a glass of wine after dinner, and you notice that night's a little rough for you, then I would start looking into that a little bit closer.
Yeah, that makes sense. We have a question that just came in saying, my friends told me to take black cohosh because it helps them. Is this a good idea for anyone?
Excellent question. So that kind of pulls into the herbal remedies and like nutraceuticals or like nutrition-y type supplement things that are out on the market. My issue that I bring up with patients is if it's not hurting you, I'm fine with you taking it. But I don't think that necessarily at the place that we're at right now with our economic climate, that spending extra money on things that aren't going to necessarily guarantee help are really what I'm going to recommend to my patients. And a lot of the nutraceuticals are not FDA regulated at all. Actually, pretty much none of them in the United States are. So you have to think about some of the studies that came out about black cohosh in particular, where an independent lab sampled and did studies to find out what compounds were in the capsules or tablets that were being sold as black cohosh. And some had a whole bunch, some had a little bit, and some had absolutely none of what is actually the botanical black cohosh. So you don't really know what you're getting. If you find something, you take it, it makes your life better, and it's not causing any harm, I'm not against it. But one, I don't know what you're actually getting into. There have been quite a few cases that have been reported of black cohosh causing liver toxicity.
Oh, so people that are actually getting the real black cohosh, whether if they know it, are having that issue as well.
Yes.
Has there been any research that shows that black cohosh, though, aside from the liver toxicity, can actually alleviate the symptoms, or is it really more conjecture?
Yeah, so there have been some studies that have really good results. However, the speculation of why that's different than sort of the real life kind of scenario, just like everything else, when it's in a clinical setting, those clinicians know we are giving you XYZ amount of actual black cohosh that's been tested and proven to have what we say it has in it. And that has actually been proven to have a significant decrease in vasomotor symptom burden. I just don't think it translates into the real world all that well.
Yeah.
So and
you have to balance that with the liver toxicity issue as well.
Yeah, I don't like to gamble, so I probably wouldn't try that one.
Yeah, no, that makes sense. What about, we've got somebody else asking, what about vitamin E?
Yeah, so vitamin E also has some good data behind it, just like actual black cohosh does. There are a lot of people that will notice a difference from it, especially if we're talking about the group of patients who can't or won't take hormone therapy or some of the other medications. It can be pretty helpful to decrease vasomotor symptom severity. Usually what I talk about is the sort of usual dose is about 400 milligrams. If it helps, great. If not, we can move to something else. But if there's other concerns that a patient would have about vitamin E, because it can thin blood, I would talk to your doctor, especially if you're prone to bruising or bleeding, or you're already on a prescription blood thinner.
Okay. And just to manage expectations, and we say for any of these things, we say if it can help, these types of things don't help overnight, right? You've got to give them a certain, I don't know how much time you'd recommend, but to see if something actually really is having an impact, what's the minimum length of time you'd want to test something out?
Yeah, I would probably give a minimum of 4 to 6 weeks to just about anything to make sure that we are giving it a good shot. Even for example, you've heard me talk about vitamin D. We can't really even get good absorption of that and good levels coming back on that until after that 6 to 12 week kind of time frame. So I would bare minimum shoot for about a month and a half.
Yeah. So just so everyone listening, this is not a try it and see how you feel tomorrow. This is a try it and give it some time, which is hard when you're dealing with a vasomotor symptom that's recurring. So some of the other, I think, tips that you shared, even the 68 degrees, just keeping your room at 68 degrees could be super helpful. Now you touched on earlier the anxiety and a little bit of that panic attack. Let's talk a little bit about anti-anxiety pills. I mean, I know you've mentioned to me when we've chatted before, there's a bit of a stigma about it, and it's sometimes hard to get your doctor to really listen. But so what are your thoughts there?
So there are quite a few anti-anxiety, anti-depression medications that can be extremely helpful for hot flashes. We have a few, we actually only have one that has the FDA recommendation for it, the FDA indication for it. It's brand name Brisdel, which is paroxetine at a kind of very tiny dose of 7.5 milligrams. So if you're looking into paroxetine or some of the other medications in that group, we have studies that show that they're very helpful. In particular, quite a few have been studied in breast cancer patients in particular to have good effects. I think there's a stigma about it because a lot of women are used to not being heard and don't feel like their clinicians listening to them, and then they get told, hey, you need to take this anti-anxiety or anti-depression medicine for these very real, very physiologic symptoms. And I hear both sides of that. I do, because I think there's a lot of women who end up taking those medications who may have other options as well. But at the same time, I think it's fair to say there's data to back up the reason that those work. So with the changes in the thermoregulation in the brain with the estrogen decline, that shows up as a decline in serotonin levels as well. So it makes sense at a cellular and a chemical level that if we increase those levels, that thermoregulation starts being better controlled. So there is really quite a bit of science behind that. However, I do think that if this isn't cutting it for you, advocate for yourself and say, hey, I don't feel like I'm being heard. This isn't working for me, or I have problems that are beyond this medication, and really look for a clinician who's going to listen.
Well, and it's also right, trying to think through, like, am I truly having anxiety and depression, or is it related to perimenopause symptoms? And this may be one way to manage it, right? And that's an important conversation that if your doctor's not willing to have with you, you need to find someone to have it with, right? Because there are, it's a tried and true. But I want to go back to, you mentioned that there was a study using anti-anxiety with breast cancer patients. And was that study to see if the anti-anxiety medication had any impact on the breast cancer, or was it just they happened to be breast cancer patients looking for a non-hormonal solution?
Yeah, so hot flashes were the goal of finding efficacy with that medication in breast cancer survivors. So I actually recently was looking at a study. It was a Cochrane review of multiple randomized controlled trials. So meaning that sort of gold standard study that a lot of doctors and clinicians talk about being like, hey, this was a forward thinking study where we gave these people this medication and looked to see if it helped. That a handful of SSRIs or SNRIs, these anti-anxiety, anti-depression medications, actually did decrease hot flashes and night sweats by a moderate amount in breast cancer patients.
Oh, that's wonderful. So there's an option right there for anyone that has some concerns about cancer. So we've talked through a bunch of some holistic, some prescribed options. So let's get to hormone replacement therapy, or HRT. And I think before we get too far, so let's start off with some stats that we're looking at this from a true evidence-based perspective, right? So let's think about if you can sort of walk us through, I'm a perimenopausal woman who doesn't have history of cancer in my family. I'm a perimenopausal woman who does have a history of breast cancer in my family. So I'm considered a previvor. I think that's the right word, right? Or I am a survivor, right? Or I guess the fourth is, or I'm in the midst, right, of trying to treat breast cancer. So if we start to look at those different scenarios, how do we, from an evidence-based perspective, start to want to evaluate? And again, we're talking very generally, this isn't for a specific person, how we might want to evaluate the likelihood that HRT could be for us and could be something we could feel safe about considering.
Yeah, absolutely. So I think I'll take off on patients that either are previvors or have a family history, but don't have a personal cancer history is probably a good place to start. So when we look back at some of the data from the WHI study in 2002, when they redid the data on that study, which I know you've spoken about with other clinicians.
But just that's the Women's Health Initiative for anybody that's listening and that's new.
A little bit of a controversial study. They went back and they redid the data, and it turns out that when patients who have a uterus are put on estrogen and progestin therapy as menopausal therapy, only an extra 1 in 1,000 patients that are getting both of those two medications are at an increased risk of getting breast cancer. So there's an extra 1 in 1,000 cases per year in those who are on menopausal hormone therapy with both estrogen and progestin. When they looked at the data in patients who had no uterus, so they didn't need the progestin, that actually was a group that had a decrease in breast cancer occurrences. So if you're looking at this from a perspective of, I'm worried that I'm going to get the cancer that my family members have, I think you should feel a little bit relieved by the fact that there was an increased risk of actually a little bit less than 1 patient per 1,000 in a year to get a breast cancer diagnosis. And there was no change in mortality. So there was no increased risk of that patient dying from that diagnosis of breast cancer.
Wow. Okay. And then you mentioned the other one that you mentioned was that there was a decrease in the risk?
Yeah. So in the group of patients that were were on estrogen only therapy, they actually noticed a decline in the amount of breast cancer cases.
And those were the women that had had either a hysterectomy or no uterus or something surgically done, which is not really, you don't hear a lot about that, right? That because, you know, one of the things we're starting to see more of, and we'll save it for another conversation, but is that hormone replacement therapy can actually be considered in some cases almost preventative when it comes to thinking about bone health and heart disease, what have you. And now we're hearing even with breast cancer, and I know a lot of research is being done on that, but let's take the patients that now either have breast cancer or are very high risk, carry the BRCA gene, what have you. How do we want to think about hormone replacement therapy for them?
Yeah, so I'll take that in two parts. So forgive me if I kind of pause on my way through. But as far as the genetic carriers or the people who are at extremely high risk of breast cancer, whether it's because you have the BRCA1 and 2 gene, whether it's one of the multiple other genes that predisposes you to cancer, or if you just have a really high number of people in your family that have had it, depending on where you are in your menstrual life cycle, the recommendations typically are that we take out the ovaries if you're at a really high risk, say for BRCA1 and 2 carriers. Those patients, we actually want to go onto hormone therapy because it prevents all of the negative outcomes that come with menopause being induced surgically. So we're talking about the heart, the bone, all of those things. But surgical menopause is a lot more drastic than natural menopause because you walk in one day with functional ovaries and the next you have no ovaries and your levels immediately plummet. It's very different than natural menopause. So we give those patients that medication not only for those preventative sort of things and to protect breakdown of bone, but because it's really miserable to go through surgical menopause.
But so yes, it is. It sounds like it's really miserable. But so I have whatever I need to have removed so that way I don't have to worry about that particular cancer. And then the recommendation, and is this North American Menopause recommended guidelines? Is this the is this cancer guidelines? Like the recommendation is to actually go on HRT.
Yes.
To not only help alleviate all the symptoms, but it sounds like it also helps decrease your risk as well. Yeah.
So if you're talking about a patient who has also a hysterectomy and can just have estrogen only, there is some data that shows that actually decreases risk of breast cancer. So just because you are at an increased risk of breast cancer doesn't mean that hormone therapy isn't for you. There are even, and this is getting like very into the woods, there are even some lesions in breast that we consider a little bit risky that are not completely contraindicated against for hormone therapy. So it's a lot more nuanced than people think.
Yeah. So who would you recommend? So I'm worried, but I also want to protect my body. Who am I speaking to? Am I bringing together a team? Am I bringing together my oncologist, my doctor, my gynecologist? Like who's really the right, or is the right group to really guide me on making this personal decision, right? Because it's not the same answer for everyone.
Yeah. So for people who are working with gynecology, oncology, or breast oncology because of sort of the prophylactic or preventative measures, we want those people involved as well. At my institute currently, we also involve medical breast specialists who look a little bit more at sort of the genetic side of it and how to mitigate risks from that perspective. But I think getting the input of all of your clinicians, your oncologist, your breast specialist, your gynecologist, everyone should be involved in sort of that decision making. Now, if we're talking about a patient who does have a history of breast cancer, there are a lot of people that immediately hear, oh, I had breast cancer, I can't have hormone therapy at all. And that's not necessarily the case. Typically, if there's hormone receptor positivity in that patient, we're not going to be recommending hormone therapy. However, there are some scenarios in which case someone like myself, who is a menopause clinician, is going to be working in conjunction with your oncologist and you to decide what's best for you.
I know that's super helpful. So we have a question coming in that's basically saying, why breast cancer? If you're saying that estrogen can impact all organs, why is breast cancer the big concern?
Yeah, so when you look back at the old data from the WHI, the Women's Health Initiative study from 2002, some of the statistics that came out at the time were not done in the most appropriate way, we found out later. And so it was lumping together groups of people that really shouldn't have been lumped together to run the statistics together. So what was happening was that groups of women from multiple different age groups were given hormone therapy in this study, and then we looked at the repercussions. One of those repercussions that was initially reported out by the initial batch of statistics was that there was a 26% increased risk of breast cancer if you took estrogen progestin therapy. That was poorly done statistics, and I'm not the best at math or statistics, but I knew looking at that data that didn't make a ton of sense, because we were lumping women together who've been out of menopause, like past menopause, for 20, 25 years potentially, that started on hormone therapy, and comparing them to a woman who's only been in menopause for a year. Those two women are not the same person.
Well, because you're comparing a 75-year-old woman to a 40-something-year-old woman at times. And correct me if I'm wrong, but I think the average, if just the average woman, there's a 1 in 4 chance of getting breast cancer by the time you're 75. Is that right? Did I get that right?
That's right. Yeah.
So whether you're on hormone therapy, just generally living, there's a 1 in 4 chance that as a woman you will get breast cancer. And I don't think they took that into account in the study either, right? Because if you're looking at a 75-year-old woman versus a 45-year-old woman, just based on the longevity of life, right?
Yeah.
Yeah. So it's, and again, I don't think we're here to say you absolutely should or you absolutely shouldn't. I just think we're really here to talk about the facts. But if you are one of those people that either does not want to take HRT or really feels like they can't, there is some new options in terms of prescriptions that are coming out that aren't hormone based, right? Like
Right.
the new thing that's coming out from Estella. So there are some other options. Do we want to maybe talk about that a little bit?
Yeah, I am going to insert right there. It's 1 in 8 women.
1 in 8. Okay.
Yes.
Thank you. Definitely correct me. Brain
fart there on my own. So there are quite a few options. So initially, when you look at the recommendations from the American Cancer Society and North American Menopause Society, the American College of Obstetrician and Gynecologists, all of those groups of people say, if you have a personal history of breast cancer, to start with non-hormonal treatments. And so I think what jumps to everybody's mind at that time are the SSRIs, SNRIs, which work very well, as we just spoke about a couple moments ago. However, there's a couple other options. So certain medications that a lot of patients in midlife are already familiar with, we use to help with that. With the control of vasomotor symptoms. So things like blood pressure medicines, like clonidine, can be very, very helpful for patients who particularly have nighttime hot flashes and are experiencing them, as well as gabapentin or Lyrica. Many patients know those as sort of nerve pain medications, but they also have activity in that same thermoregulatory zone in the brain. And another medication that's fairly commonly used in cancer survivors is oxybutynin, which is a medication that's intended purpose was to help with overactive bladder, but it can really do a good job at decreasing the sweating and the flashing with vasomotor symptoms. Now, you touched on the one new up and coming drug that's really close to being done with its FDA review right now. The drug name is fezolinetant. And so that happens to be focused a little bit more on those other receptors that we were talking about, that estrogen binds to those receptors in the brain near the thermoregulatory zone. But there's a lot of other chemicals that bind there. So this medication is directed at blocking those so that those fluctuations are not triggered.
Wow, so that's a lot of different options that you can talk to your doctor about outside of hormone replacement therapy, which is really great, especially if you have any fears or concerns of either getting cancer or having cancer in your family. So we're getting a question saying, I know we're talking a lot about breast cancer, but what about uterine cancer? Was there any research in that study in 2002 that showed that HRT has more likely to impact uterine cancer as well.
Uterine, yeah. So prior to some of the studies, I believe it was like in the 80s and 90s that this data started kind of making a change, or might have even been the 70s. Sorry about that. They were looking at doing the estrogen replacement therapy for patients who were going through the menopausal transition, finding out, hey, it does actually really help these patients with their symptoms. And then, oops, later we found out that there was an increased risk of endometrial or uterine cancer. So when a patient has a uterus, we now know that that patient always has to have a progestin or progesterone to balance out the estrogen that they're being given. That progesterone's job, or progestin, depending on if it's synthetic or not, its job is to protect the uterine lining from getting thicker from the stimulation from the estrogen. So estrogen progestin combination therapy does not increase the risk of endometrial cancer. Estrogen therapy alone, or what we call unopposed estrogen, does.
Because the thicker the lining gets, the more likely you'll start to have abnormal cells. Is that the?
Yeah, so I like to think about it as like the longer things sit there, the longer they have the chance to sort of mutate. So if, you know, it's like gray hair, like the longer that one's around, the longer it's got to make that change. Yep. Or, you know, that old moldy milk in the back of your refrigerator, like leave it by itself and it may, you know, have something bad happen to it. If that is never allowed to develop or it's forced to shed, then it can't sit around and mutate.
Okay, no, that makes a lot of sense. So we talked a little bit about communicating with your doctor, but you know, a lot of us struggle with getting a doctor's attention, men and women, just because, you know, with insurance, what have you, you know, you're in, you're out there. And also we find that a lot of doctors just aren't well versed in menopause, or frankly, just aren't very empathetic. And we know that a lot of these symptoms are really, they're exhausting. They're depressing. They really can impact work productivity, etc. So what are some telltale signs that your current doctor may not be the right person to discuss menopause with? And what's the best way to broach the topic? You know, I'm on the younger side. I'm noticing that, like, you know, I'm more anxious or I'm sweaty, but I don't really know anything about perimenopause. I've never really heard anything about it, right? We're starting to see it a little bit more in the news and the press, but how do I start to say, oh, maybe that's what this is, you know, and how do I get my doctor to start to think about that as well?
Yeah. So initially my first thought is that if you speak to your doctor and you bring these things up and they have a pro or anti-hormone therapy stance, that's not the right person to talk to. Because if a doctor has a personal position on a guideline recommended therapy, then that's not who's going to be able to help you. That's almost the same as saying that a doctor would have a personal opinion or stance on giving someone with high blood pressure medicines to treat it. If it's a problem and you fit the right description of the person who needs that treatment, that's who needs to get it. So if your doctor is saying, I don't do that, or, oh no, that's bad for you, or some negative connotation regarding it, just kind of on the whole, I would walk out and go to somebody else. Now, if you're worried about something, say that you're, you know, in your early 40s and you start having hot flashes and you don't know what to ask about that, and you kind of get into these conversations that direct themselves toward mood or stress or whatever else have you, don't be afraid to ask that clinician, do you think this is perimenopause? I'm worried about perimenopause, or I'm worried I'm in menopause. Here's why. At the end of the day, most clinicians should be able to point you in the right direction. But if that's not happening, you are your strongest advocate. So going to the menopause.org, which is the North American Menopause Society website, typing in your zip code in the little Find Menopause Provider Near You page, click, you know, enter, and you'll be able to find clinicians near you that are North American Menopause Society certified in menopause.
Yeah, no, that's great. And for anybody that's listening, you can go to menopause.org, or if you ever forget the email, the URL, we also link directly to their physician locator on letsalltalkmenopause.com. And in addition, Let's All Talk Menopause now has a directory. So every doctor that we've interviewed, you can also reach out to them as well. But I think your point of making sure you find a doctor that is a certified NAMS practitioner is a really valid one. And, one of the pieces of advice I was given, even within the gynecological practice that you're in, is to ask if there's a doctor that specializes in menopause. Because sometimes they do have one in the practice. So that's super helpful. We just got a question about Vagifem from a woman who's 65. She's been on it for about 10 years and is just sort of curious as to, and again, we're not prescribing specifically for her, but is that a long time to be on Vagifem? Can you be on it forever? Like, what are the guidelines there?
Yeah, so the guidelines over time have changed, and systemic and vaginal get confused for each other all the time. So systemic is what we're talking about when you take a pill or rub a gel on your skin or put a patch on. Local or vaginal hormone therapy is very different. Those hormones are not absorbed in any appreciable amount into your overall bloodstream, so they're not going and binding to other places. If you talk to a lot of sex specialists or urogynecologists, other menopause clinicians that I work with, a lot of those clinicians basically say there's no need to ever stop them. As soon as you start them and you see improvement, you don't need to worry about stopping them. I think as long as you are noticing the improvement in the quality of your life and you see the benefit, there's not risks that your doctor is addressing with you, mind you, someone who's menopause trained, then I think it's fair to stay on it forever if that's what works for you between you and your doctor. There's no reason to stop it. And there were old guidelines that said for systemic hormone therapy to be the smallest dose for the shortest amount of time possible. One, that wording for systemic got changed, and two, that applies in no way, shape, or form to vaginal estrogen. So if you want to stay on your Vagifem forever and your doctor agrees with it, go do it. Yeah.
No, that's great. Somebody's asking the question is, are some HRT medications safer than others?
Yeah, so there's different combinations of hormones that are available. There are different kinds that are potentially interpreted. I hear a lot as safer when we talk about transdermal or through the skin than oral. That only really comes into play if a patient is at an increased risk of clot or heart disease, something that makes us concerned that giving oral estrogen that goes through the stomach and into the liver and kind of can alter those clotting factors would be potentially more risky. So for some people, transdermal is a better option, but I don't ever look at them and think, oh, that one's dangerous or that one's the safe one. It's a very person specific recommendation.
And so the follow-up there is with the pill, I guess it goes into your, it gets digested, right? Whereas with the patch, it doesn't. Is there anything to think about there?
Yeah. So when patients are saying, hey, I want to mitigate the risk as much as possible, I like to go through my risk stratification with them of why I think they would be a better fit for oral versus transdermal, meaning a pill or like a patch or a gel. And sometimes I have patients that say, hey, I know you said, Dr. Fiffick, that I have a really, really low risk of blood clots. I've had multiple babies. I've been on birth control for 30 years. All these other things that are much higher doses of hormones. Some patients just don't want to do that because they think, hey, if I don't have to digest it and I can just stick on a patch and it doesn't increase the clotting risk, that's what a lot of patients will opt for. So talking to your doctor and really understanding your personal risks may help you decide better which way to go. Unfortunately, I would love to say that insurance doesn't play a role in it, but sometimes it does. So noting that you're having that conversation with your menopause clinician about where they think your risk stands, what they think the best options for you. But there's very rare times that I've ever looked at somebody and said, well, this is your only option.
Oh, that's great. So that's actually a great note to end on, is that there are a lot of Well, we've gone through a lot of them, right? There's a lot of different options if you want to go holistic versus medication versus hormone therapy. And even within each of those, there's a lot of different options, especially as it relates to vasomotor symptoms and especially as you're thinking about your cancer risk. So I guess I'm going to ask you my usual closing question is, if we have time for one last thought, what's the one message you'd like our audience to take home with them tonight?
My biggest message for my patients or any person that I see on the street is that you know your body and you need to advocate for yourself. I think that for a very long time, women's experience in healthcare has been that they feel like they're not being heard. And it doesn't help. I know that Dr. Men said this before. It does not help you to be the nice girl. You need to advocate for yourself, for your sister, for your friends, and say, hey, I'm suffering, I need help. And if you can't help me, who can? And I think just knowing that there are people out there that you can eventually reach that will be able to help you is very empowering.
Oh, that's a great message and such an important one. Thank you so much, Dr. Fiffick. I mean, you've really given us a lot of great information tonight on a subject that's difficult to begin with, and then if you layer cancer on it, becomes really, really difficult. So we really appreciate your time tonight.
I appreciate the opportunity to be here and talk about what I love so much.
I know, right? We're both pretty passionate, which is awesome. Well, it's been really great having you. Thank you so much. And for anybody that's listening, if you do want to learn more about the topic or what Dr. Fiffick has been working on, is you can always go to speakingofwomenshealth.com, which is the website that Dr. Fiffick is affiliated with. And thank you again to Astellas Pharma Global Development and Bayer Healthcare Pharmaceuticals for supporting education in women's health. It's so important for us all. We really appreciate their support. And thank you all for watching. I hope you'll join me next Tuesday, February 28th, for a very special edition of Let's All Talk Menopause that will be hosted by primetime newscaster and menopause champion Tamsin Fidel. We are so excited to have Tamsin come in as a co-host of Let's All Talk Menopause. She'll be speaking with Dr. Rachel Cady to learn more about why our bones become more vulnerable during peri and menopause and what we can do to protect our bone health. And please remember that we're not offering medical or clinical health services specific to your situation. If you need help, please contact your doctor or other qualified medical professional, or go to menopause.org and look up where you can find a NAM certified physician near you and ask them any questions regarding your personal health or your medical condition. And please don't wait to get help if you need it. And don't forget to keep up to date with our latest information about what's coming up in the future by reading our newsletter or following us on Instagram. You'll find us at letsalltalk.menopauseus. And this episode will be available to watch as soon as we come off air, so please watch it again. And if you like what we're doing, please share with your friends and family. The more women we can help, the better. And with that, I wish you all well and good luck taking control of your menopause experience.